Hello, and welcome to the Texas Mind Exchange podcast. My name is Cody Gould, and I'll be your host. Today, we were joined by Dr. Ty Schepis of Texas State University. He is a faculty fellow with us in the Translational Health Research Center. We were lucky enough to have him join us and talk about substance abuse with adolescents and family. He talked with us about the future of substance abuse research, and we talked about some of the grants that he's working on with SAMHSA. So without further ado, welcome to the Texas Mind Exchange. Just as a reminder, all statements expressed by our guests on this podcast are their own and should not be considered official views or opinions of myself or anyone else at Texas State University. Ty, thank you for joining us.
Thank you for having me.
You're welcome. I am excited to have you here. Yeah. I've heard, obviously we've worked together in the past. Mm-hmm. I know that you're doing some amazing research that I want to learn about. And I'm excited to share you specifically with our audience because with my job at the Translational Health Research Center, I'm so community focused. Like my whole job is to make sure that what we're working on translates to the community, that I haven't really interacted with many of our faculty fellows and researchers. That I'm excited to kind of get the word out about what you're doing and the amazing research and stuff that you're doing. So to start there, I would love to hear a little bit about your background. I know this is going to be a big question, but I would love to hear a little bit about your background, and maybe we can go into like some of the research that you've been working on recently.
Okay. So to keep it from getting too long,
you can take as much time as you want.
No, you know what? I'm not going to start with, well, I was born. Let's start with college. So I actually was pre-med in college and wanted to be a physician, and was my joke is I carried it to the absurd length of actually going to medical school, and then through a series of events started having a few panic attacks, decided it was not a good fit for me. And so the joke in our household is that I'm the medical expert because I have 2 weeks of med school and I am in no way a medical expert. But that sort of started me on the path of, well, A, I'm having these panic attacks. What's going on? And B, maybe I need to find a new career. Maybe I need to find a new focus. And so I started therapy, as many people do in these kinds of situations. Can't recommend it enough. And in the course of therapy, sort of realized, hey, this is really helpful. What I want to do is help people. And maybe this is something I could do. I could do clinical psychology. That seems interesting. I've always been interested in why people do the things that they do, even when the things they do aren't very helpful to them or to others. So started to go down that path, got a job at UT Southwestern where I had gone and then dropped out of med school, working in a clinical trials clinic where they did depression and anxiety trials. So I got to work with people who had depression, who had anxiety, which is a great experience for folks who are interested in mental health, because I think you need to know if you can handle working with these folks. It's a lot to spend not 8 hours a day, but spend a few hours a day, certainly, across from people who are depressed. Their energy, their concerns can be pretty draining. And so I found I could work with these folks. They're interesting. I like them. And applied to grad school, got into a clinical psychology program, also at UT Southwestern. I couldn't get away for a while. And got into the program, course is going well, started doing therapy, started doing research, and I figured out within probably 6 months or a year that as a clinical psychologist, you can do three things. You can teach, you can do research, you can do practice. Most folks go into practice. Maybe they do a little teaching on the side. Some folks do research, but you do some combination of those things. And the thing I was the worst at was therapy. I was just the worst at therapy. I'm not patient enough. I realize this about myself, and you have to allow people to get better at their own pace to a degree. Obviously, if they are suicidal, if they're going to maybe hurt somebody else, if they're doing really dangerous things, that's different. But if they're just depressed, I certainly had experiences where I wanted to say, you know what the problem is. I know what the problem is. Why are we just not fixing the problem? And they weren't ready to fix the problem. And you can't force someone to fix the problem if they're not ready to fix the problem. So I started doing research and really found that I enjoyed it. Again, it scratched that itch of why do people do the things they do, especially when they are unhealthy, when they are clearly things that we all know don't help people succeed in life. So I got into doing my start really in substance use research, which broadly is what I do, was doing smoking cessation research with adolescents and young adults. And that sort of formed my dissertation. And then I went and did a postdoctoral fellowship at Yale School of Medicine for 3 years in their division of substance use, where I was doing both still the smoking stuff and then doing research on prescription drug misuse, which is really what I do now. That's the primary thing I do now. And that was a great experience. And I learned a ton, and it led me to Texas State, where I've been for 16 years now. I think I'm starting my 17th year.
Wow. Amazing.
Yeah.
Thank you for sharing that. That's, you make it seem like it happened so fast, but I'm sure that there is,
like anything, it was obviously a long process.
Yeah.
I mean, I just glided over. I've been here 16 years. There's a lot has happened in that 16 years, obviously. And the 3-year fellowship, a lot happened. In grad school, a lot happened. But this is not a 3-hour podcast. So
totally,
I've got to keep it a little snappier. But yeah, there was a lot going on in those moments, but that's the 5-minute version, if you will.
What was it about substance abuse and substance misuse that really got you interested in it?
So it's sort of a twofold answer. Again, in the same way that I didn't intend to leave med school, I didn't start med school with the intention of, wouldn't it be funny if I'd stopped after a few weeks? I didn't actually go into grad school intending to do substance use research. The program I went to at UT Southwestern is a pretty clinically oriented psychology program. So their mission is more to train clinicians. Most clinical psychology PhD programs, the faculty really want to train researchers, but the reality is the world needs more clinicians than researchers. So most folks go into clinical work, but at UT Southwestern, it's really heavily towards the clinical work. And I got there, unlike a lot of programs, you're not necessarily accepted to do work with a specific mentor or in a certain area. But when I got there, I started to work with someone who was doing what we would sort of broadly think of as health clinical psychology work on pain and lower back pain and rehabilitation. And he ended up taking a chair position at the University of Texas at Arlington and left. And there was still the opportunity to work together, but I wasn't too thrilled about Arlington, Dallas, not that far apart, but still working with someone who was an hour or more away. So we had a relatively new faculty member start who was doing the smoking cessation research. And I thought, well, that's interesting. I don't know why people smoke. We all know it's unhealthy. So I would be interested in doing that, and got into it. And I think ultimately that's what's kept me there, again, is this idea of, particularly with smoking cigarettes. The Surgeon General's warning has been on cigarette packages for, at this point, well over 50 years. But even at that point, when I was in grad school, over 40 years. And so people know smoking cigarettes is unhealthy. Why start? Why continue? That was sort of the set of questions that motivated my interest and kind of kept me going. And again, that's what sort of kept me going is, broadly, who are the folks who are likely to do this? Who are our high-risk folks? Why do they do that? What other concerns maybe does this relate to? I said that I started in smoking cessation work, and I did other kinds of treatment work. that is obviously super important. Really, though, for me, I'm more interested in the who and the why than the how do we fix it necessarily, which the who and the why leads into how we fix it. But treatment is a whole other area of research. And I always appreciate people who do it because it's so time and effort intensive just to get one research study out on that. So.
Oh yeah, I'm sure it seems to be a lot of odds and ends to pull together, to put it lightly.
Yeah.
But I'd love to go, I guess, into some of that research that you've done. I guess we can talk about the smoking cessation one. It just seems so interesting. What did your research find in regards to some of that? I know it happened a little while ago, but I just find that so interesting of understanding the who and the why. And kind of going from there.
Sure. So some of what we did was the who and the why, but that was more treatment oriented. And I can just talk a little bit about that. And she's moved in a completely different direction because this was over 16 years ago since I've been here that long. But my mentor at Yale was really interested in a few different, what we would describe as behavioral treatments for smoking cessation. And she had this awesome access where she could work with students in, I want to say it was 9 New Haven area high schools, not in New Haven actually, because New Haven and Yale don't always have the most awesome relationship, but around New Haven, she had access to the schools and we would go in and recruit, and kids who smoked could sign up to take part in the research. And we had a deal worked out basically with the schools and then the ethics committee in the School of Medicine, where parents would be informed about the study. And if they didn't want their child to participate, they needed to let us know. But otherwise, their child could participate. We were concerned about kids needing to tell their parents, by the way, I smoke and now I'd like to stop. It could be a real barrier to them getting treatment, and them getting treatment's the whole point. That's a thing that's positive. But the research looked at a pretty well-known, well-supported form of therapy called cognitive behavioral therapy. So your thoughts, your behaviors, and then how that related to smoking. And then the other part of it was a thing called, the technical term is contingency management, which is basically just, we will give you a reward if you haven't smoked. And so something people always bring up is, well, how do you know they didn't smoke? Would they just tell you they didn't smoke? They would lie to you. Of course they would. So we could test their breath, and we could test a urine sample for carbon monoxide in the breath, and in the urine, something that in the body, nicotine gets broken down into that's excreted out in the urine, to see how long it had been since they smoked, roughly speaking. And if they hadn't smoked in the past week, they would earn money. Other studies do this with other drugs, and they've given people bus vouchers, or they've given people gift cards for McDonald's or things like that. It doesn't actually have to be a lot of money. And it would compare, that particular study sort of compared cognitive behavioral therapy, contingency management, and then both. And the short version of it is that contingency management, giving people rewards to quit and then keep away from whatever drug it is very effective. Obviously, the problem is when you stop giving the reward, a lot of people do go back to it. But even 6 months later, it's still more effective than just the cognitive behavioral therapy. So that was something that we looked at. But it's tough to get the money to do that sort of thing. There's interest in that kind of research, but then you have to translate it into a program that some agency can keep doing, and the costs of it can add up after a while. And you certainly get people who get upset because they say, why should I pay for someone to quit smoking? They shouldn't be smoking. Well, sure, but that's not the world we live in. And it's going to save us so much more money to help these folks, whether it's quitting smoking, reducing their alcohol use, use of an illicit drug. All of this has been studied with contingency management. I'd rather have these folks stop and get the long-term health benefits, cost a lot less long-term in terms of healthcare and support that they may need, their inability to work because of these things. So it ends up being a very cost-effective treatment, but there's not always the funds or the broad popular support for it.
Yeah. What I hear in that is something actually similar that we spoke with Dr. Kelly Cleary about what happens when we focus on prevention compared to just reacting to what is going on. And what I hear from you is similar to that of from a long-term oriented perspective, maybe from a long-term oriented public health perspective, the prevention of getting somebody early into their potential smoking career could have amazing positive ripple effects from a public health perspective. But that also clashes with, why are we investing in this? It's this person. It should be this person's job for them to stop.
Absolutely.
And I would love to hear more about, like, are we making progress from that perspective in research, or are we still kind of dealing with that mentality, do you think?
Oh, I think we're absolutely dealing with that mentality. And I think that the way I've put it recently is we are in an era of really limited budgets for health. There's a lot of cost cutting at a state level, but there's certainly a lot of cost cutting at a federal level for things like Medicaid, for other health-related programs. There were lots of cuts in health research. There's proposed cuts that are quite large. And yes, that will potentially save state government, federal government money today. But in 20 years, they will be paying many times over that in the cost to treat the problems they either didn't prevent, to get to what Dr. Cleary was talking about, or the problems that they didn't catch early and intervene with and help people, whether it's substance use, it's mental health, it's physical health, help people get back on a healthier track. Long term, those, again, substance use habits, untreated mental health issues, untreated physical health conditions, they become more and more and more expensive. They don't become less expensive. And I think it's really short-sighted of folks to not see that longer-term perspective. It frustrates me, even as somebody who, I don't smoke. I don't do any of these things. I get my exercise. I try and eat carefully. I try to do those sorts of things, but I would much rather help other people who may struggle with some of these things be healthy, not least because it just improves their life. I just think that's a good goal and outcome in and of itself. And then certainly it does have long-term economic benefits for society. So I think it's a both and, but to answer your question again, I don't think we're necessarily better about that. I think it tends to come and go in waves and cycles where people get concerned about it. People are more willing to spend, but right now I think we're in a phase where people are not as open to that.
Mm-hmm. Has your focus on research, obviously it seems to have dovetailed into something a little bit different from smoking. What has it kind of transitioned to now?
So when I was in graduate school, actually, I first started to learn about and do research on prescription drug misuse. So that is using a potentially addictive medication in ways either that the prescriber didn't intend, so doubling up on the dose, using it more often, combining it with other drugs, things like that, or using one of those medications without a prescription. And so the medications we're talking about are pretty well-known ones like opioid medications that led to, in part, the opioid epidemic and the overdose epidemic, stimulant medications for ADHD, which is a real focus right now, both in the research world and in the policy world, because there's some real concerns about increases in prescribing that have occurred. And then medications for sleep or anxiety, like benzodiazepine medications. Xanax is a really good example of that people may know. These are the medications that were most interested in from that kind of prescription misuse lens. And so I was interested in kind of shifting that focus because I looked at the people who were doing smoking research, and there are a ton of smart, talented, hardworking people who do smoking and nicotine research. And at that point, this was before vaping became a thing. Vaping did not exist at this point. And if I had known vaping was going to exist, I would have stuck with it a little bit more, because that was a really big transition and a neat point to jump in sort of on the ground floor. But I looked at smoking and I said, I can do smoking research. Again, answering these questions of who and why and what are they doing. But I would be looking at pretty narrow pieces of the puzzle, because a lot of people are looking at it. There's already a lot of existing research. So instead of being able to maybe answer more fundamental questions, I'd be doing kind of niche stuff. Or I can look at this prescription misuse area of research and really start to answer more basic fundamental questions, because not a lot of people are doing this research. There's not a lot known about it, but it's something that's starting to get covered in the popular media a little bit. It's something people are becoming more interested in and aware of. So I want to pivot, and it was a pretty conscious pivot, to do more of this prescription misuse research, because I think it will allow me maybe to make a bigger impact than it would in the smoking field.
Mm-hmm. And what are some things you've been seeing or finding, or some trends?
So we really saw, I'll do opioids first.
Yeah.
We really saw in the 2000s and in the early 2010s increases in prescribing of these medications. So I want to be clear, this is legitimate prescribing for health conditions. If folks listening or watching have ever had surgery, if they've ever had a serious painful injury, they probably were prescribed an opioid medication. That's pretty common. But we saw increases in prescribing, which means there's more medication available out in society, which made it easier to steal, which made it easier to give away to others, to divert, and was probably a huge part of why rates of prescription opioid misuse went up and up and up and up. But people became aware of that problem and really concerned about that problem in the early 2010s. And so when people think about the opioid overdose epidemic, it really kicked off with the shift from prescription opioids to heroin, and then really, really, really took off from heroin to fentanyl and other drugs like fentanyl. That occurred around 2016. And that's when you see these really sharp increases in overdose. It had been going up. Rates of overdose had been going up, but really sharp increases at that point. Well, with changes in prescribing, with changes in the way that these prescriptions are monitored, people now, as compared to even 5 years ago, I had shoulder surgery. It was about 5 or 6 years ago. So it was pre-pandemic. And my orthopedic physician did not know what I did and came into our pre-surgery office visit to prepare for my rotator cuff repair and said, okay, well, I know you've heard a lot of scary things about opioids, and I'm going to write you a prescription because it's really important to control your pain, and I want you to go get it filled. I know you're probably going to be worried about it. You've heard these things. And my wife and I are trying not to laugh out loud, because this is actually an area I know more than the surgeon does. And I said, okay, I'll go get it filled. He was very insistent, and I did. And I am not personally a big fan of opioids. I don't tend to need them with surgery. My pain was controlled in other ways. And I do want to stress, if people need them for pain, they need to take them. It is important. But I just had the prescription for a month or two, took it to the San Marcos police station where there's a deposit box, got rid of it, moved on. Now, if I was to get that surgery, I might get 3 to 5 days of opioids. And I was getting something more like a 2-week dose potentially of opioids when I had the shoulder surgery. So all of the changes in prescribing and monitoring mean now it's a lot harder to get opioid medication. And there really is a feeling among some folks in research, especially folks who maybe do pain management kinds of research and clinicians who work in that area, that maybe we've gone too far. But one real trend we've seen is that misuse of opioid medication has gone down, that misuse of a lot of medication classes has gone down. And then with COVID, they really dropped off for a while. And it's, I think an outstanding question is, have they started to rebound? We don't really know. But we really think that when society in general went into lockdown, and obviously in Texas, we had less lockdown than in other parts of the United States, but everybody was pretty skittish about getting together socially and associating. Those networks where you could get an opioid medication, a stimulant medication, any of these kinds of things for misuse, well, they dried up. You weren't going to see, a lot of my research is in adolescents and young adults. So you weren't going to see your friend who had ADHD at school, who maybe doesn't take that prescription on the weekends, so he has a few extra pills. You weren't going to see your roommate in the college dorm who has some Xanax for anxiety, but kind of just takes it as needed, so she might have some extra pills. Those disruptions probably led to some pretty significant declines in misuse, but I'm curious if we're going to see a leveling off or even a little bit of an increase, but it's a little too soon to know. Right now, it seems at most like we've kind of leveled off, but that's not even clear.
How do you, what data sets do you typically look at that, I guess, like help you kind of see some of these trends?
So if we're looking at kind of a population-wide picture of prescription drug misuse, the two major data sources that I've used are the National Survey on Drug Use and Health. So that is a big nationwide survey that in a typical year will survey 65 or more thousand people across the United States, age 12 and older. And then they will release a publicly available data set that's usually about 55,000 people. Well, in research, that's a ton of people. Research often can be, depending on the type of research, 100 people, 200 people, those can be big samples. So 55,000 is an enormous sample. And we've used that data to look at different trends in prescription drug misuse. And we were seeing kind of declines in young adults in particular, so 18 to 25, a little less so in adolescents, pre-pandemic in prescription drug misuse. But the pandemic kind of changed how that survey was done, so it makes it a little hard to look before and after the pandemic and kind of compare. There's some unfortunate changes there. And now there's some real concerns about whether that survey will even continue to exist due to budget cuts. The staff who ran that survey out of the Substance Abuse and Mental Health Services Administration, which is a federal agency, they were laid off, basically. They were RTF'd. They were part of a reduction in force, or RIF, I should say. And it's not clear if even the 2024 data will come out. That data has been collected. It's 2025. But it's not clear that those will come out. 2023 exists. Years prior to that exist. So that's something that I'm really concerned about, because it's a data source that not just myself, tons of researchers use to monitor changes in all sorts of different drugs, how use of different drugs relates to each other, some of the processes that go into it. So that's a real concern that we have. The other big data source is a survey that's run out of the University of Michigan called the Monitoring the Future study. It started in the 70s and has gone since. And it started as a survey of, I believe, 12th graders. And then they added 8th and 10th graders later. But they would take 12th graders in schools across the United States and survey them. And again, produce estimates that were representative of that 12th grade population as a whole across the United States. But a really cool thing that they did was then they took a subsample, let's say 2,500 of those students a year, and they would try and follow them over every other year through about age 30, and then every 5 years after that. So this has been going on long enough that they have folks who've completed the age 60 assessment. And that is another great source of these kinds of data. And some of my most frequent collaborators, folks I work with, are at the University of Michigan, so they have access to this data. And we can use that to answer a lot of questions as well. As of right now, that data doesn't seem to be under threat, but all of that is uncertain, which is pretty scary.
Yeah, absolutely. I'd like to talk a little bit about some of those grants that you were just talking about, specifically the ones that you're on, and where the trajectory of your research has been moving. It sounds from the sound of it, the trajectory is substance abuse, substance misuse, adolescence. Done a lot over the years. What are the current moving parts that you're working with right now? The current grants.
So I have a grant from the National Institutes of Health that looks at changes over time, kind of what we've been talking about with some of the trends in prescription drug misuse in both adolescents and in young adults. So some of it is about comparing adolescents and young adults because they are different groups. Young adults have much higher rates of prescription drug misuse. So if you see an adolescent who's engaged in prescription misuse, it's a lot scarier in terms of what that probably indicates about other substances that adolescent may be using, mental health concerns that adolescent may have, versus a young adult, where it's still a concerning sign, but it does seem like it's a much scarier signal of risk in adolescents than it is in young adults. But we're also looking at, okay, can we look pre and post pandemic? Can we look at how they get these medications, sources for the medications, and how that's changed? I kind of talked a little bit about that with the COVID disruptions. And we're also interested in the why, which in this case is motives. So what are your reasons, motives, for engaging in prescription misuse? And those motives typically line up with what the medication is intended to do. So stimulant medication, most folks, even adolescents and young adults, are still engaging in misuse of a stimulant medication to do one or more of help them concentrate, help them focus, help them study, help them pay attention, things like that. But a lot of it is still a minority, but a sizable minority is, well, I wanted to experiment. I wanted to get high. I wanted, if it's a different drug like an opioid, I wanted to maybe sleep or just feel a little better, things like that. So that grant looks at all of those different things. I'm also on a grant that is funded, or I should say a research contract, from the Food and Drug Administration. And that one is stimulant medication specific. So they're really interested in adolescent, but we've kind of shifted, because this is the second version of this award, into looking more at young adults and changes over young adulthood in prescription stimulant use and misuse. So we're also interested in use, because I think a real concern is, I mentioned this earlier, prescribing for ADHD, prescribing of stimulant medication really went up around the onset of the COVID pandemic due to increased availability of telehealth, among a number of other factors. But it seems like access may have gone up. So there's a real question, though, of, well, is this access for people who legitimately need it and are getting real benefit from it? Or is this too much access in the way that opioids were too much access? And we're still obviously doing the research, but I think the early signs are that this is more legitimate access for people who need it, and that the worst things we saw with the opioid epidemic are not as likely to be seen with stimulants, even if, as opioid and kind of fentanyl involved overdoses really come down, overdoses that involve stimulants haven't really come down and may even have kind of gone up a little bit. So stimulants are a problem, but those stimulants are typically methamphetamine and kind of things like that. So not the prescriptions. That's a different issue.
Yeah. What reason might you associate with why some of those overdoses have been coming down? Is it just because people are using those drugs more accurately as they should be, or is more like street level drugs are not as prevalent?
I think so it really is, overdoses coming down is really about fentanyl.
Okay.
And those fentanyl overdoses, those fentanyl related overdoses coming down. A lot of times we see this, there are drugs this doesn't apply to, but a lot of drugs tend to cycle. And a lot of drugs, my joke is it's like the old whack-a-mole game where you hit one and the prevalence of one goes down because it gets a lot of attention and focus, and then one comes up at the same time, and then you're hitting multiples and it gets harder and harder. We're not necessarily in the it gets harder and harder part of the cycle, but we tend to see a drug like cocaine might get a peak and then it kind of goes back down. And the peak is people forget about the harms, people forget about the risks, and use might increase. And as people start to overdose, as people in social networks start to have problems with the drug, start to need treatment, and again, start overdosing and potentially dying, other people who may be exposed to, in that case, cocaine, in this case, fentanyl, or drugs that can contain fentanyl, start to be more concerned about using. They start to shift their use towards other drugs, or just not use those kinds of drugs at all. And I think that's what we're seeing with fentanyl. It took, in some ways, longer than I would expect because it was so hazardous and the increase in overdose was so severe and so stark. But I think what ended up happening was that people really got concerned about use. They got concerned about pills where they weren't sure about what was in the pill. And to kind of get at that, I'm also you interviewed Dr. Clary, I'm part of her SAMHSA grant that goes into schools and does educational programming with the kids around substance use broadly, but is pretty specific to fentanyl in each grade level. And the students we worked with, we did a first round of programming in a local school district in the spring. They were very aware that pressed pills are a dangerous thing. I think it can take some time to seep into people who are in adolescence and young adults, are highest risk folks to start using these drugs, but I think it has. And I think those folks are saying, not worth it. I've known people who've overdosed, or I've seen the ads. I'm not going to do that.
Yeah, it sounds like the education around it has been pretty, I guess, hitting home the effects of what could happen, which is, I guess, is important to educate the potential consumer of that.
Yeah.
And similarly, what you're talking about now, what I'm going to say now is completely anecdotal, and it's something I would like to talk with you about because you're an expert about it. But you mentioned earlier that if you were on the forefront of the vaping, I guess we can call it epidemic, that would be like a really interesting topic to go into. Now, I've seen not only a rise in vaping, but there seems to be, again, anecdotal, a rise of nicotine consumption just generally.
Yeah.
Do you have any, I guess, thoughts on that? Why that might be more prevalent?
I think, if anything, nicotine has probably just shifted. I've been fortunate enough to go to Europe a couple of times recently. Went with family to Italy over Christmas one time, and then was at a conference in Germany. And I was amazed, especially in Italy, at the number of people who would just be on the street smoking. And you really don't see that in the United States anymore.
Yeah, I feel like I've been seeing it more recent. Like I've been seeing it more maybe through different types of like vaping or pouches or things along those lines. But yeah, that's interesting.
And so I think I'm not a big fan of shaming people to do things, but I will say I think we have really shamed combustible cigarette smoking in the United States, and people still do it, but they don't do it nearly as much. And they do it maybe more secretively. Texas State implemented a smoking ban, and it's been maybe 8-10 years since they did. And at the time, I think most people on campus supported it, but there was definitely pushback among people who smoked. And for a few years after that, you would still see people trying to sneak their spot to smoke on campus. And you just don't see that anymore. That really does not happen. I think part of that is that instead of combustible cigarettes going down and nicotine use going down, it's just pivoted to vaping. It's pivoted to the pouch use. And so all those folks who are on the street in Italy who are smoking a traditional cigarette, in the United States, they'd be vaping. Because while I don't see people smoking cigarettes, I was driving by PetSmart recently because I had to pick up dog food. We have dogs. And there was a gentleman who needed to take one last hit of his vape before going into the pet store. And that's what you see now, where you would have seen that person smoking the cigarette outside the store 15 years ago. Now they're vaping. And given the differences in how you use a vape versus a cigarette, it can be easier just to do one quick hit of a vape, go into the store, then when you come out, do another one. The dosing is kind of different in that way. So I don't know that it's necessarily gone up. I just think how it's used and people's comfort with using in public has changed.
Interesting. Yeah. I know that was a little bit of a tangent, but it was something that kind of popped up with me just because, being in my kind of middle career, I feel like it's now just so prevalent to see people. And I've now even seen nicotine marketed as a cognitive enhancer and things along those lines. And that was the big thing for me. I wanted to see if there was any research being done on this, because it seems to be a lot of more research being shown into the benefits of nicotine. Whereas, historically we have the opposite perspective on it. And it just seems to be a little bit of a fascinating conundrum.
Yeah, well, definitely for nicotine, the most harmful way to use it is a cigarette. But the biggest harms from that come from the fact that you're inhaling the smoke. There's the tars, the ashes, all the carcinogens that come with smoking. Basically, for those folks who've been camping or ever done s'mores, if you just stand over the fire and inhale that smoke, you know it's not good for you. And it's the same sort of thing with cigarette smoking. We don't really know, I think, with vaping, whether it's safe or harmful long-term. There are a lot of chemicals in the liquid that people use in a vaping device that could be potentially kind of harmful. And my advice is always, if someone's going from smoking a cigarette to vaping as a form of something we call harm reduction, you're still going to use a substance, but you're going to do it in a less harmful way. I think that's absolutely great. If you had a 40-year-old who'd been smoking for 20 years, now I'm going to vape. I don't want to quit. I'm going to vape. Well, that's still a win. That's still an improvement. But don't start vaping just to vape. It's still probably a harmful thing. Nicotine does have cognitive properties. Nicotine is a stimulant. People don't think about it that way because people who use nicotine kind of consistently think of it as something that relaxes them. They're probably dealing with their withdrawal symptoms, so they feel better because they're no longer in withdrawal. But it is a stimulant. People, when they use nicotine, are a little more alert, a little more awake. That's some of the cognitive enhancement stuff that nicotine can do. It's almost certainly not worth starting. And I don't think anyone really thinks the benefits outweigh the risks at all. And I would contrast this with another drug. People don't think of this as a drug, which is caffeine, where as long as you use caffeine at low, even up to moderate doses, it seems neutral. And depending on how you use the caffeine, maybe even healthy. Something like coffee, something like tea, there's some evidence that might be healthy. Now, drinking a ton of, I'll be Texan, Dr. Peppers, probably not so healthy. There's a lot of evidence that's not healthy, those kind of sugary beverages. So caffeine is either kind of neutral or healthy. But again, there's a lot of thought that instead of people being more alert, awake, and focused when they take caffeine, they're just no longer in withdrawal anymore, where they feel more sluggish and tired and fuzzy. And so it's not that you rebound to better, it's that you rebound to normal. And that may be what's going on with nicotine as well.
Yeah, interesting. Thank you. Thank you for that little tangent.
Yeah,
that was fun. I'd like to transition back a little bit to talk about how you've partnered with organizations and local organizations. Obviously, all the work that you do doesn't stay in a silo. It goes out to the community. Have you, like, what does that interaction look like if you have partnered with either local or national organizations to help disseminate all the amazing stuff that you're doing to kind of make sure it gets out to the public?
Yeah. So usually, I mean, that kind of comes in two different forms. So sometimes it comes in the form of a media interview, and I sort of joke like media interviews are like rainstorms in summer. They just kind of pop up sometimes, and you don't really know when they're going to happen. You can sort of anticipate, oh, I'm putting out this article. It might be of interest to media. It might be of interest to folks in the wider public. So I might get requests for interviews, but I've put out papers where we've done press releases and it's crickets. And I put out papers and not done a press release, and I get approached by a lot of different media enterprises, different interviewers, podcast papers, radio, whatever it is. So that's one way to get out the research. And in a lot of ways, that's less of partnering and more of them calling and saying, hey, we'd like to do a story on this today. Can we talk to you between this, this 1 hour window? I joke that media people are always working sort of on deadline. It's just they're trying to do it minute to minute, it feels like. And I'm usually great at accommodating that. I'd be happy to do it. For working with local agencies, a lot of times what we're trying to do there is educate clinicians, stakeholders, other policymakers, and things like that. And again, a lot of times they will approach me about doing a webinar. I'm going to be doing a webinar later in the summer on kind of trends in college student drug use, just broadly. And that's with a higher education center at Ohio State University. And I'd done one with them before, about 2017, and they approached me again. And so we're gonna do it again. So in a lot of cases, those just kind of seem to kind of happen organically as well. It's something I think where those agencies either see something interesting in what we're doing, or they identify a need and want to find someone who can maybe speak to that need and come and find me, and I do that kind of work.
You said something I thought was interesting was people reaching out to you to have you talk about the thing that might be interesting in general. What would you say is one of the more interesting things that you have found or that you usually communicate to the public?
I don't know that there's one message that I try and send out, but I will say, maybe this is answering a slightly different question. We had a couple of papers come out recently where we were looking at using that national survey on drug use and health. Adults who said they had children in their home who also had a substance use disorder. And so how many children, what do these parents look like? And we're doing work on that. And it's a surprisingly large number of parents and children. We estimated it was somewhere around 19 million children live in a household where one, maybe more, at least one of their parents has a substance use disorder. Most of that's alcohol use disorder. And the way that a substance use disorder is diagnosed changed about a little over a decade ago, and probably captures more people. I think that can be good in that you may capture people who still have a level and pattern of alcohol use that's a problem, where there's some kind of intervention is needed. Maybe they don't need to go to a residential facility for 30 days or 60 days, but they need some kind of intervention. It's getting to be problematic. So we saw a big jump related to that change in how it was diagnosed. That was one of the papers. And then the other one used data from 2023, and we found about over 19 million children lived in a household where a parent had a substance use disorder. And so now we're looking at the parents, and it's about 1 in 6 parents of children has a substance use disorder. And so we're trying to figure out, who are these parents? What is the pattern of their substance use? How severe is it? Things like that. I think people are shocked to hear that, but I also think a lot of people who may drink really regularly would be shocked to know that they might have an alcohol use disorder in the new criteria. And so that's one in particular that got a ton of media coverage, because anytime we're talking about children or adolescents who are affected by something, there's a lot of interest in that. Parenting, there's a lot of interest in that. So that was one that got hit, and people's eyebrows definitely went up when we would tell them the numbers.
Yeah. My brain immediately goes to, okay, what are the implications of this?
So these children, if we focus on the children, are at much higher risk of their own substance use and substance use problems later on in life. They're more likely to start using early on. They are more likely to use heavily, to develop a substance use disorder. But they're also more likely to have mental health problems. They're more likely to get involved in the child welfare system. And I do want to be clear, if there is really serious neglect or abuse going on in a household, that absolutely needs to be reported. The child welfare system needs to intervene with those kids. But in a lot of cases, getting involved in child welfare is not that good for kids. And our goal really needs to be to stop it before we would even want to involve child welfare. So identifying these kids, I think our point in the research was to say, look, there's this huge population of kids where a parent has a substance use disorder. How are we identifying these kids? The answer is almost certainly no. Are we doing anything to help these kids? Well, if we're not identifying them, how can we help them? And so it's sort of, the point of that is to start the discussion of, who are these kids? How do we find them? And then what do we need to do when we find them? So to answer your question, step one is to find them, I think, to even just identify these kids whose parents have a substance use disorder. Because I think of myself, I have 2 children, 2 boys. And whenever I take them for their annual exam, no one asks about my health. No one asks about my substance use. Nobody asks about me. I'm not the patient. The pediatrician's not concerned about that. But my behaviors affect my child. And I think this is my wife works in healthcare, and she often says, we don't have a healthcare system. We have a sick care system. We intervene when you have a serious problem. We don't get ahead. Again, back to Dr. Clary and prevention and early intervention. We're intervening when there's some really serious problems going on. And if we could catch things earlier, that would help. But it also takes such a change in the system we have, in the healthcare incentives. Doctors aren't necessarily incentivized to do a lot of assessment, to do a lot of preventive care. They're really there to say, oh, you've got the flu. Here's a prescription for Tamiflu. Oh, you got the flu. It's 4 days later. Just get lots of fluids, watch it, call us if you still have a fever in a few days. That's kind of the incentive. So these kids whose parents have a substance use disorder, maybe schools can identify some of it, but they're probably identifying it when that child is starting to have problems. Maybe healthcare offices can identify it, but if they're identifying it, it's probably because the child tells them something, or a parent comes in obviously under the influence of drugs. Well, that's already a pretty severe situation. So there's a lot of kids, I think, who live in these households where it's what we would describe as a mild substance use disorder, which is a bit of a misnomer, because mild almost makes it sound like it's not that big of a deal. It's still a pretty big deal. Those are the kids who I think fly under the radar and then suffer for it in adulthood because that environment may not have been a great one to grow up in.
Yeah, so I guess holistically understanding how development is impacted by all of these different parts. I liked what you said about when you go into the doctor and you bring your sons, the pediatrician doesn't ask you any questions. No. I literally have never thought about that before. That's such an interesting and very pivotal moment that could be really impactful for the development of your children or other children and parents out there. That is fascinating to look at the family system compared to just that particular patient in that moment.
Well, and we're even at a point, I think, where it's gotten better. We love our pediatrician and we love our pediatrician's office because it's part of a bigger practice. But they only recently started asking the adolescents about depression and anxiety symptoms.
Wow.
And those are really common in adolescence. That's when these typically start. That's when anxiety disorders and mood disorders typically start. And they've just started asking about those at that point in the annual well checks. So we are many steps away from asking a parent about substance use, for instance, because they're not even asking my older one's about to turn 17. They're not even necessarily asking him, they didn't ask him at 16, if he's using any substances. And so to get to the parents, that's multiple steps down the road. But those healthcare providers, they're not reimbursed for that. That is time that they are not paid for. And I know that they and many other physicians I've worked with would love to do things like this, would love to identify and intervene early with whether it's a family problem or a problem just with that child. They'd love to do that. But unless you as the parent bring that problem to them, or it's really obvious, a lot of that stuff just goes unnoticed because they're not paid for that. They're not incentivized to take that time and effort.
Interesting. Very interesting. I know we're coming close to time, but I would love to ask one more question.
Absolutely.
The one more question the question I have is, maybe it has to do with this, but where do you think the future of your research is moving? And what are some topics that you would really like to dive into?
I would love to look at something I've always been interested in, and I've done some of with my research, but it's hard to do. I would love to look at how mental health and substance use interact. There's a lot of research that links the two with poor mental health and substance use, but I think there are a lot of outstanding questions about how the two work together and whether one causes the other, or they're both influenced by kind of a common set of characteristics. To give sort of an example, people who are more, the word for this, and it's kind of a Freudian word, neurotic. People who are more anxious and have more negative emotions overall, well, that predisposes them to mental health concerns. But it doesn't have to be a specific one. It could be an anxiety issue. It could be a depression issue. It could be something else entirely. Also may predispose them to substance use, but we don't know, is it that higher order thing? Are the two interacting? How do they interact? What causes what? There's some real questions about that, and I would love to look at that. But the honest answer for where things are going is I don't know, partially because a good part of what I have done is to use these big data sets, these big nationally available, nationally representative data sets to look at substance use and links with mental health and other factors. But if they go away due to funding cuts, and this is less important than the other effects, I lose that sorts of data and that ability to answer those sorts of questions. But much more importantly, we as a country lose information about what drugs are emerging, what drugs are being used more or less often, why maybe those drugs are being used, what kinds of things go along with that drug use. And so I don't think those data sources will completely go away, but I am concerned that they may be reduced. And so partially because I certainly 16 years ago couldn't have predicted what I would be doing now. I certainly wouldn't want to predict in 10 years from now. It's hard to say, but it is also hard to say because there's some real concerns about funding cuts and what that may mean for the future of research and drug use research specifically.
Yeah. Well, Ty, thank you for joining us today.
Absolutely.
If people have questions or want to reach out to you, what's the best way to do that?
They can always email me. I am on the Texas State website in the Department of Psychology. I'm not that hard to find. I am out there and available. So yeah, email is the best way to do it. And I'm happy to try and help out again, whether it's talking to clinicians in the community or other organizations. Happy to do that kind of stuff.
Amazing. Well, thank you so much for joining us.
Thank you for having me.
Of course. This podcast was presented by thecentralstate.com. Thecentralstate.com is a consortium focused on improving resilience in Central Texas by using evidence from research to improve human and community health. This website highlights health and research data by county and opportunities to find funding and resources for mental health programs in our area. Additionally, there are interactive calendars that keep you up to speed regarding what is happening right here in Central Texas.